We've got a few studies on the docket. A lot of them say the same thing. There's one that draws an erroneous conclusion, but let's just hop right in. So the first one on the docket talks about complex regional pain syndrome, and they wanted to see what is a potential reason why people suffer with complex regional pain syndrome. So first up, what is it? Essentially, it falls into a category where patients have a poor pain response to different stimuli. So somebody has pain in regions they can't explain, and that's why they name it that way. It's complex. We don't exactly know. There's a lot of mechanisms to it. Regional, it affects regions of the body. Pain syndrome, it's just a myriad of painful symptoms that patients experience in different parts of their body that really has no rhyme or reason that we can always pin down, and it affects the quality of life thereof. We can think of it in a similar tangent to fibromyalgia, where people have a mismatched pain signaling issue. And while these things aren't necessarily or inherently deadly, where they're going to lead to a loss of quantity of life, it is definitely something that affects quality of life. We have family that actually has fibromyalgia. We have other people in my family that have other various conditions in a similar vein. And what this study wanted to see is, as far as a potential mechanism, a physiological mechanism, what is happening in this patient group so that we might be able to target it more effectively with interventions in the future. So when it comes to pain signaling, it is an extraordinarily complex subject, but let's try and keep it simple and break it down this way. Just like a car, you have a gas pedal and you have a brake. Your brain basically has your brain and body has the gas pedal send a whole bunch of signals to the brain so it can give you the pain signal, and that kind of gives you the warning of there's something that I feel is dangerous or harmful that you need to be aware of so you avoid it. Then it has the brakes where it's just like, I'm going to, yes, we're getting the signal where part of the body should be experiencing something like harm, like injury, but I, through various other means, don't think I need to send out the pain signal because I don't think it's dangerous or I don't have time for that. So let's use a real world example that usually works better than just talking at it like this. So as far as a situation where people apply the brakes, you're swimming out in the middle of the ocean, you get bit by a shark, your leg comes off. In that moment, everybody looking from the outside in should be like, man, that person must be in a lot of pain. They just had their leg bitten off. When you talk to anybody who's gone through a significant trauma in the moment, they feel nothing. They feel legitimately nothing. The brain is applying the brakes. It's inhibiting the signal so that you can get out of that situation. The brain's just like, I hear you. We were just bit. I don't have time for that. I need to get gone. And if I'm worried about, sitting in a fetal position because of the pain, I'm going to lead myself to getting more harm, more hurt, more pain. So it puts on the brakes, gets you out of that situation. Now, let's go to another scenario. Paper cut. Fresh, warm paper cut, a little bit of lemon, a little pinch of salt. That's almost no actual physical damage outside of a tiny itty bitty little cut, but anybody knows that hurts like crazy. So, gas. That's all it is. Gas with no brakes. The brain goes, all right, there's the signal. I don't need to apply the brakes whatsoever because there's nothing else in my environment that says I need to run and get out of here, and I can devote all of my attention to that basically painful stimulus, that injury. So it is full gas, no brakes, whereas the other one was gas, yes, but full send on the brakes. I hope we understand that. Reason being is if we go back to the study, they set up two groups, a control group and the group that actually had complex regional pain syndrome. They had a testable pain threshold stimulus. Basically, patients would have what's called an algometer, and they would measure how many pounds of force under this square inch, or basically a PSI. How much PSI could a patient withstand before they hurt? Then they used a control stimulus, a cold water immersion, to see how well all group participants did modulating their pain, or discomfort would be a better word, because like putting any part of your body in freezing water really, really sudden from a warm room is very uncomfortable. It's not necessarily inherently painful to everybody, but it's uncomfortable. So what did they draw from this? I'll read the conclusion, and this will probably make more sense than me just explaining the rest of this. The results indicate that individuals with that chronic regional pain syndrome their pain inhibition, so being able to apply the brakes, is intact. So where they're feeling the pain, the reason they're feeling the pain isn't an issue with the brain being able to put on the brakes, because they said they had the same results compared to the healthy individuals. Therefore, they postulate, or they are guessing based on process of elimination on what they found, that the pathomechanisms, or the reason that people feel this pain, is likely related to increased pain facilitatory mechanisms. Basically, when they're applying the gas, oh boy, they are stomping on the gas. And the brain goes, whoa, okay, fine. We have an issue. I will listen. I'll hold off on the brakes because I don't see anything else going on right now. Pain. It's right now the easiest way I can explain it. So if anybody has questions on it, feel free to ask me. But I want to move on so that we cover all the studies in a succinct amount of time. Next up, here's the one where I think they drew an erroneous conclusion. Effectiveness of fascial manipulation versus eccentric training with static stretching on patellar tendinopathy. Basically, manual therapy versus eccentric loading with stretching. How does it compare? They set this study up already in favor of fascial manipulation, and let me go into the details and we'll get into why. So first up, the setup. How was the study set up? This randomized clinical trial was conducted in a physiotherapy department. A total of 88 patients with tendinopathy were recruited and given either the 4-week eccentric program with stretching or once weekly fascial manipulation treatment for 4 weeks. The outcomes were various pain questionnaires, disability questionnaires that you don't need to know the names of them, pain scale ratings, pain pressure thresholds, patellar tendon thickness using an ultrasound device, etc. Now, what were the results? Of the 88 people, 86 completed the study. The mean scores improved across all groups, so both fascial manipulation and eccentric training. And both groups were improved at 4 weeks, 3 months, 6 months, and 1 year follow-up. The thickness of the area in the patellar tendon they were measuring was reduced at 4 weeks in both groups. And on one of their scales, the surveys, 80% of patients with the fascial manipulation group and 40% in the eccentric training group reported complete recovery. Both groups demonstrated a significant effect size across all outcome measures at 4 weeks. And the problem is they emphasize that 4-week mark. So I'll read the conclusion, I'll give you my thoughts. While both fascial manipulation and eccentric training with stretching led to similar improvements, fascial manipulation appears to be superior in terms of the number of treatment sessions required and patient satisfaction. I do not like the way that they structure that sentence. I do not think that it is nuanced enough for somebody just reading this, and it was a pseudo gotcha conclusion. What we know about manual therapy is it's beautiful in the short term. And if your sentence structure is emphasizing, yes, at the 4-week mark, holy moly, patients reported all of these things, it's too sterile of an environment and it's not realistic. And it's not probably going to get the same results when you look at it at the 6-month and 12-month mark when you have patient satisfaction, because other factors will come into play. Let me explain. So if we take the time frame of 1 month with a painful condition like patellar tendinopathy, I'm not against manual therapy in the slightest, because we have plenty of studies and evidence to show that manual therapy in the short term helps to reduce pain and usually increases patients, it decreases barriers essentially. So if we have 2 patients where one is kind of stoic in nature, wants to save as much money as possible, and is a bit of a go-getter, you don't really need to give them manual therapy. Just tell them what to do and act more like a coach on the side. Hey, instead of needing to see you like I would somebody that I'm doing manual therapy with because they want it, you're somebody who clearly can handle the uncomfortability of the condition, and the best thing long term for you is just to make sure that we're getting you moving in a controlled manner, and et cetera, et cetera, et cetera. So we'll see you periodically just like a training coach. We'll give you a program and do check-ins instead to give you progressively more difficult exercises that your tissues tolerate to let them adapt. And in that case, we're probably talking, depending on the program, every 4, 6, 8, 12 weeks, depending on how confident the patient is, how much pain there is, and how many other conditions you're juggling at the same time. Versus the manual therapy group, or a person who wants the manual therapy, if the condition is so painful that they can't do the exercise, yeah, we'll see them more often. But the manual therapy should, if we're doing it correctly and we got the right diagnoses and all the right things, and there's no other things that I need to be aware of, we should be able to, within that short window, reduce their pain enough to get them to do the exercises, and then eventually get them on the same idea, the same programming as the person, basically person A versus person B. And that really comes down to patient personalities, the severity of the condition, lots of other factors as far as what makes me choose and talk about the patient with different treatment models that might be best for them. But let's go back to the study. So if we then take a look at 6 and 12 month marks, I would suspect that you would see a vast shift towards the eccentric model unless the person likes being pampered and has unlimited funds. Reason being is when you do manual therapy, it's typically an add-on service. Or it's taking up time that you could be devoting to exercise when you see the person for your care. So if you needed to get over the hump in the first month, great. Typically, it shouldn't be something that you're incorporating long-term because we don't have good evidence, and it doesn't, like mechanistically, the manual therapy doesn't work at that long-term stage. So if we have two groups of people, one who's just doing the eccentric training program mainly on their own with periodic check-ins, I would suspect that they have a better satisfaction with what they got versus the person now that, if they stick to the model of the study, once weekly manual therapy treatments for 12 months, that adds up because you have to take time away to do the manual therapy treatment, and now you're also paying an individual to do that manual therapy every single week. So over the course of that year, you're taking more time out of your day, you're paying more money, and at the end of the day, you're going to get pretty much the same result. So I think this study, the conclusion, was a little bit rushed and trying to paint it too much in favor of the fascial manipulation. What I would prefer is if they said, within the 4-week time structure, fascial manipulation showed a better result, again, for reasons that we know about because it works in the short term, but similar results would be seen at 6 and 12 months. That's all I'm saying, because again, if the 6 and 12 month mark showed same or similar results, the people receiving fascial manipulation, you're not saying don't exercise, don't move, don't do anything else. You're just not. Okay? So I think I don't like the study because it wants to say one thing but then sneaks in another. I'm getting off on a tangent. Let's just finish up the studies. Next up, enhancing rehabilitation outcomes in chondromalacia patella, so a different reason that the kneecap is painful. The impact of combining manipulative therapy with a structured exercise program. I'm not even really going to get into the details. This is just another one that shows multimodal approaches to a patient's care typically yield superior results for the reasons that I essentially just highlighted in the previous study. When you get people out of pain in the short term, or you're improving their ability to do the activity that you actually want them to do that leads to a long-term result, they will be better off for it. That's all I got to say on this one. Next paper. Oops, pressed wrong button. Effects of non-thrust joint mobilization on clinical outcomes of patients with adhesive capsulitis of the shoulder, a meta-analysis. This one had basically a caveat, like, here's the conclusion, but proceed with caution. Like the last two studies, it seems that with this condition, which it's an interesting condition because there's a lot of different potential metabolic factors that go into adhesive capsulitis, frozen shoulder. It's pseudo self-limiting in the sense that a couple years ago, like 20 years ago, it was like all manual therapy. There's nothing you can do for it. You feel better. Manual therapy might help. Yada, yada, yada. Like 10 years ago, 6 years ago, it was nothing helps at all whatsoever, and it'll go away on its own between 16 months and 3 years, give or take, depending on the person. And so people were just suffering in the dark. And now there's some new studies that, yes, we can't seem to make it go faster. No, that's the wrong way I want to say it. We can't seem to make it clear up within like 1 month, like that's what we there's no way to do it. There's the mechanisms behind the condition, but it's like we're not generally satisfied with saying it's, patient, do your own thing for 3 years and it should go away on its own. There's now some evidence out there that's hedging. We might be able to trim a few months off if we approach it with exercise programs, potentially manual therapy. I'm sure there's other studies that are looking at different metabolic, chemical, pharmacologic interventions. So it's not going to be like a cure where it's like once it's starting, you take this pill, do this exercise, you won't go through the process. They're now seeing if there's ways to cut months off of the total time to recovery. That's the way I want to say that. So with this one, it kind of said something similar in regards to the quality of life of patients going through, not the duration of adhesive capsulitis, but the quality of life of patients going through it with manual therapy, i.e. non-thrust. So just basically mobilizing the shoulder, having a practitioner just passively take that shoulder through ranges of motion, challenge it a bit, etc. So conclusion, I like the way that they say this. This meta-analysis found statistically significant improvements in the reduction of pain, improvement in function, and restoring of range of motion among patients with adhesive capsulitis, regardless of technique utilized. I like that. And they have the caveat. However, results should be interpreted with caution because there are levels or lack of quality in some of the studies in the field. So it's like, here's a good direction, but proceed with caution, don't promise the moon. I thoroughly respect a study that says that. So something to consider if you have adhesive capsulitis and it's going to be annoying, but you're going to be okay. And there's things that we seem to be able to do that might help during the process of recovery. Now, next up, last three. These are going to be quick, except for the last one, kind of. Relationship between BMI and pain with peripheral muscle strength, disability, and quality of life in patients with cervical radiculopathy. TLDR, long story short, if you had an excessive BMI, all of your metrics for cervical radiculopathy were worse, including recovery. So one of the things that this study says that you should include in your treatment approach for patients with cervical radiculopathy, so pain shooting down an arm, stemming from the neck for various reasons, could be a disc, could be an acrotic, lots of reasons. You need to take a whole body approach, a whole person approach, and not just focus on the symptoms of the neck. You should also consider trying to reduce their BMI so they have better clinical outcomes. That's all that one said. Next up, optimal dosage of exercise when it comes to patients with fibromyalgia. So this one's interesting because exercise is shown to have great benefit, but the nature of fibromyalgia, it's very easy to overdo it, overexert, and then go through a very painful recovery process. It's like DOMS on steroids, delayed onset muscle soreness, and patients just suffer because even though it's good for you, it's also easy to overdo when you have this condition, and it's hard to recover, and people then don't want to do the exercise. So they wanted to see what is a good dosage consideration. And really it comes down to making sure that we have at least a minimal effective dose, i.e. an amount of time you don't want to go under, or an amount of exercise you don't want to go under, because if you do, then it's almost like it's not that you're not going to get any benefit, but you're not really going to get any huge benefit. So let's see, where's the numbers that they had here? Because the way they phrase it is kind of confusing, but if you piece it out, there it is. A minimum dose of at least 50 minutes per week and a total duration of 600 minutes were estimated to effectively reduce pain intensity. The maximum effect was achieved with 90 minutes per week and 1,200 minutes with total duration. And additionally, there was found to be a minimum effective dose of 65 minutes per week with a total duration of 950 minutes per week to effectively reduce one of the survey scores for the patients going through with fibromyalgia. So basically, first thought was, you need at least 50 minutes, but if you get to 65, you're even that much better, because now we see that some of these survey scores come down even further by adding in that 15 minutes. So I would hedge my bets for most of my patients to get at least in this, if I was only basing my clinical intervention of exercise for this patient population on this study alone, I would say, you'd want at least 65 minutes of aerobic exercise per week. There's additional studies, if we can tolerate it, for people without fibromyalgia, you want at least 150 minutes per week to get other additional cardiovascular benefits. And what I liked is that in this one, they found that there was at least a maximum effective dose was obtained with that recommendation of 150 minutes of cardiovascular exercise or aerobic exercise per week. Now remember, that's just aerobic exercise. That's not strength training. This is just, anything to get your heart moving: running, jogging, swimming, elliptical, biking, rowing, etc. So it lets us have a more nuanced conversation for people going through this, because just off the cuff, I usually give them the minimum recommendations, which there's, let's see off the top of my head, minimum of 2 resistance-based exercise, two times weekly minimum of resistance exercise, while you're also trying to get at least 300 minutes a week of some moderately vigorous level of activity, or 150 minutes of high level activity per week. And you want at least 150 minutes of that to be aerobic exercise for cardiovascular benefits. I always shoot for more. It's like, you never want to shoot for the minimum, because if you miss the minimum, whoops. If you kind of shoot for more than what you think and you had a bad week and you didn't quite hit it, you're still probably above the minimum. So it's just, in my opinion, clinical opinion, a little bit better to shoot farther, miss, so that you still get the benefit, rather than shoot for the minimum, miss, and then you don't get really anything. So for fibromyalgia, yes, you still get benefit upwards of 150 minutes, so the same recommendation, but now you have a range that we can hit that gives you at least a minimum effective dose. And I'm going to shoot to tell my patients, based on this study, at least 65 minutes if you have fibromyalgia. So still something that we got to tighter and make personable to the individual in front of us, because fibromyalgia stinks. It's not fun to work with from the patient standpoint, because it's fatiguing, it's painful, it really eats into a lot of quality of life things. So we got to find ways to make this both fun and approachable. And maybe it's one of those, you can't tolerate that 65 minutes per week initially, but it's now your first stepping stone goal that we want to build you up towards. And yeah, I like having these in my back pocket to reference, to give patients the confidence of a more personable approach. Like, okay, he's not just saying this because it's, they did some studies on this, and this is something that I can now work towards. It's a tangible thing, not a nebulous, out in the air, just based on his opinion thing. So I like it from a communication standpoint. Speaking of patient experience and satisfaction with chiropractic care and national survey, the big things and why I wanted to pull this study that stood out is really how I set up my clinic, is what patients seem to really, really like. So they surveyed 250 clinics, or they wanted to survey 250 clinics. 228 came in, which recruited roughly 27,500 patients to go through these surveys. And what really stood out as far as why patients are typically so satisfied with chiropractic care, because overall satisfaction rates of very high or high were surveyed to be at 97% of the responses. So 97% of that 27,500 people said that they were very high or high in overall satisfaction with chiropractic care. But it really comes down to why. I'm not saying, pat myself on the back because I happen to be in a profession that gets that number. I want to piece out, why did the patients answer that way, and why do I want to tell you about it? So overall satisfaction was associated with personal experiences involving the chiropractor, particularly in the areas of examination, communication, patient involvement and information, and perceived effectiveness and reassurance. So of those things, it highlights building the rapport with the patient in front of you, and how many indirect factors play into clinical outcomes, i.e., you could do a fantastic treatment to the patient that still won't be as effective as a placebo in certain situations if the person likes the provider a lot. And we see that with these, body language things, first impressions. And when people are going through a typical medical system that doesn't really always respect that interaction, that rapport building, where you go in, you're just another name on the chart. You're given 5 minutes with each provider. So nurse takes you back, gets your intake, quick takes your blood pressure, is typing while she's not facing you or he's not facing you. Then they're like, I'll go get the doc. The doc comes in, takes a look at your screen, barely takes a look at you, does the few necessary things that they have to do to make sure that you're not dead or dying or there's not something that is big and scary in front of them, and then just give you a script or something and go out on your way. You're not going to be satisfied with that level of care, even if in the moment it was medically appropriate for you and what your condition was. Flip the script. Typically, the privilege of my profession is that we get to build those relationships in a whole bunch of different ways. Now, granted, I'm comparing apples to oranges. You have great systems, great providers in the medical world, just like you have very terrible systems, clinics, and providers in mine. But on a general principle standpoint, we are more about building relationships, at least at this clinic. And that leads into satisfaction from a patient outcome standpoint. And I thought it was interesting that the things that they highlight are the things that I try and emphasize as far as our clinical approach is concerned. So being able to take a thorough examination that is individualized to the patient in front of me for their condition. Being able to communicate exactly what's going on. So we have various steps that we take to make sure that everybody's on the same page at my office. Making sure that you're involved in the process, the clinical decision making as far as what's relevant and important to you, and me explaining why I think certain things when it comes to your condition, care, etc. And as far as perceived effectiveness and reassurance, I don't necessarily like the perception side of things. I really just like to show, I don't like trying to do the whole dog and pony show of, aha, you are, no. If you're going to get better, we have ways to demonstrate it objectively without my bias getting in there. So all results are from you, your work getting put into it, and it's something that I won't compromise on. Now, here's another interesting thing that I'll talk about, and I want to give my 2 cents and then I'll end this video. Lower satisfaction was linked to experiences involving delays. We don't do that because we're always one-on-one. We're not a mass clinic. Unexpected adverse events. Unexpected being the key word. We cannot always guarantee there won't be an adverse event. That's the nature of healthcare. What we do is terribly safe, but that doesn't mean that there's not the risk of adverse events. I tell patients all the time, exactly through an informed consent, hey, if we do this treatment, here's what I would expect. Here's some possibilities. There shouldn't be any unexpected thing happening. And frankly, it's helped tremendously. We don't see those poor satisfaction scores, or patients aren't unsatisfied with our care simply because we inform them, hey, if I do this treatment, we could see some redness, we could see some bruising. If I do this, you're probably going to be sore, explaining all along the way so they know exactly what's happening. And a lot of the times patients come back like, yeah, you were right, that I was very sore for a day or two. Or, yeah, you were right, it did, whatever it is you did, I was both sore and there was a bruise, but 2 days later, I am so much better. There were, quote unquote, according to the literature, adverse events, which aren't bad. They're just adverse. They're different pathways that people go through when you're giving them a treatment. So patient A, do treatment. Patient B, do same treatment. Patient A, no adverse event. Patient B, they got a little extra sore. Adverse event. You tell patients that that's a possibility. They're typically fine with the results, especially since you're including them on their care. Now, this one is interesting. The last thing that led to a lower satisfaction score was the process of collaboration with other healthcare professionals. Now, why might that be? And I think it comes down to, at that stage, poor optics of communication when it comes to the patient. So when it comes to working with other healthcare professionals, that could be a lot of different people. That could be massage therapy, MD, DO, that could be a lot of different things. And oftentimes what happens is when a referral is made, the doc doesn't explain what, when, where, or why. So in my opinion, and I'll double check this just to make sure that it's only my opinion, patients, when they are seeing that there's a collaboration with other healthcare professionals, if it's somebody like massage therapy or an additional service, especially if it's within the same clinic, you could be giving a poor perception that you're just trying to mill them for more money. Versus if you're referring them out, but not saying what, when, why, or how, two things could be happening. One, you're giving a perception of a lack of confidence for that patient, which they don't appreciate, and or you're not giving them a understanding of why they're being sent out. So when they go to see the other provider doesn't know why they're there, and then it's just a waste of time. So there's a lot of things that we can do to set up our patients for success if we're collaborating with other healthcare professionals. The first one is clear communication to the patient about what, when, where, and why we are considering bringing in this other healthcare professional, and just being upfront and honest with them. The second thing is also communicating clearly with the provider that you're sending them to. So one of my goals is to still build out more of a name-by-name basis with other providers that I will typically refer to. So it's never satisfying for me to say you just need to see your GP or just go to this hospital system. I much prefer having a name-to-name basis, like, oh yeah, no, you see Dr. Sue or you see Dr. Bill. Yeah, let me give them a little call about why I'm sending them your way, giving them a heads up so that the care is genuinely collaborative, not just a brush off. The last thing that I want to make sure that we do is, if I'm sending a patient away for a given reason, that they have that they know why, and that they're able to ask additional questions and get additional clarity with this other provider. And that could be just sending them with a script of, hey, you've got a condition that could go either way, conservative care or surgical. We're sending you to an ortho. I want you to be able to ask these questions of the ortho to give yourself a clear picture about what's going on, so that you're not just wrapped into a system and that you're put under the knife unnecessarily, because that's what the system does. And that's just what the system does. So, hey, here, ask these questions, make sure you understand, A, B, and C, so that you can make an informed decision about what is best. So that if you do need the knife, you asked all the questions, you needed the knife. If you don't, you were able to ask the questions, figure that out, and then we'll come back to our clinic or wherever is most appropriate for you, and then work collaboratively with what you've got going on. So that's my opinion about why that survey was done and why they found it was a less satisfactory result when patients are being collaborative in their healthcare, or when providers are being collaborative with the patient's healthcare and they're not satisfied with that. So that's why we do things the way we do things. And yeah, I'd love to tell you more about my clinic. So message me, DM me, contact me. I'm an open book. Thanks for sticking along, and until next week.